Oops. Hi there, this is Dr. Jess with Premier Physical Therapy, and today we're going to be talking about neck pain and headaches and what we can learn about those and then what we can do about them. So a little bit about us real fast is that this is a clinic named Premier Physical Therapy. We're locally owned, meaning that we're owned by a physical therapist and not by a medical doctor or corporate institution, which means that everything that we do here is from a complete PT perspective. So we have specialties that include all orthopedics, which means we can treat anything from pain in the big toe to pain in the head. We've got a specialty of lymphedema, oncological rehabilitation, head and facial pain, sports and injury performance training, as well as some post-surgical rehabilitation. So for the most part, if something's going on, we can probably help you. Now, as far as where we need to start when we talk about neck pain and headaches, I always like to educate my patients on what the normal anatomy is, because the more that we understand normal, the better that we can then understand the abnormal and then what happens when things are abnormal. So first things first, we have bones. We have bones that make up the neck. So we have what we call the upper cervical spine. So that's right there at the very base of the head. So if you can feel your skull, right when that skull starts to drop off, that's where we start to get these first two bones, the atlas and the axis, and they have a little bit of a different type of mechanics than what the mid-cervical spine has, which starts around C2-3 down to C6-7, which is down where we feel that kind of the biggest bump that comes out at the base of the neck. And then we transition into what we call the cervicothoracic junction, which is just as we transition from a curve in the neck from one direction, then once we hit the thoracic spine, that curve switches directions. So we go from a lordotic curve to a kyphotic curve. And that cervicothoracic junction is where that transition zone happens. So very different things can happen at the upper cervical spine versus mid-cervical spine versus that cervicothoracic junction. And understanding the nature of just the bony anatomy and just the change in that curve helps understand why do some of these things happen. Other things that we need to know are there's muscles. Muscles help to control both from a deep level the spine itself. So these are the muscles that actually have direct attachments to the bones. So that gives the spine stability. Okay, so there's some really important muscles that a lot of people don't really know about. They're not muscles that when you go to the gym or work out, you're like, oh, I'm going to work my deep cervical neck flexors. But in the PT world, these are a big deal. And these are the things that we really tend to focus on as far as trying to combat dysfunction. And so this is just like a quick look at what some of those muscles might look like. And the first picture here shows some of the muscles in the front of the neck, but they're deep, deep, deep. You can't touch them. They're deeper than some of these more superficial muscles that you can feel. And then the second picture shows some of the muscles in the back of the head itself. And these ones in the back really can contribute to headaches, which we'll get to in just a little bit. All right. Now, other things that are important are nerves. So nerves are a big deal. They can be referring pain from different areas. And they can contribute to sensory dysfunction, meaning motor dysfunction, loss of use of specific muscles, loss of sensation, and or pain as well. And so we've got cranial nerves that innervate into the head and face, and then we've got what we call the brachial plexus that exits from the spine through some of the musculature here in the neck, comes down into the shoulder and arm, and then out and innervates the rest of the arm. So all things that we wanted to have an appreciation for. And then when we are screening for dysfunction, all of these are different things that we are taking into account. Now, as far as neck pain, so what does that mean? It's a very broad term. So when someone's like, oh, I have pain in my neck, what do you do to treat that? Right, so we got to get past this very general term, because we get into more specific details of what could be going on to cause the neck pain. So neck pain is simply a sensation of discomfort in the area of the neck. That's it. Now, that tells me nothing about the actual cause of the dysfunction. So what we're going to review today are some of the more common causes for neck pain. This is by no means an exhaustive list. This is not everything and everything that could happen. It's just the things that are more likely to happen. So what we're going to cover are what's called disc pathology. And that's when you might get an MRI and it says something like degenerative disc disease or stenosis, things like that. The other thing that we're going to cover a little bit is what we call temporomandibular dysfunction. So that's the jaw, the TMJ. Something else we're going to cover, some just muscle imbalances and strains that can happen. Facet entrapment. This is the one where you kind of wake up and then you can't move. Like, I was fine yesterday, now I can't turn my head. What in the world happened? We're going to cover whiplash and then headaches. All right, so let's start with disc pathology. This is the one that everybody loves to get. They take pictures of their pain because the picture, clearly is what's going to be the end all be all of understanding why I'm hurting, which, as we know, is not always the case. So disc pathology means that we've got something wrong with the disc that sits in between the bones. It could be bulging, it could be herniated, like I said, it could be degenerative. There's a bunch of different diagnoses. That does not always mean that if the imaging is positive, that's the only source of why you might be having pain, though. All right, so 40% of people that have disc pathology, so something is wrong on their MRI, are asymptomatic. So that tells us a lot that, like, we can't go just based on imaging. We have to look further into what's going on, okay? So the symptoms that you're experiencing need to actually correlate with the findings on the MRI. If the symptoms don't correlate with the findings, then we need to look further. Maybe it is more of a muscle strain. Maybe it is more of a facet entrapment. Maybe there's like all sorts of muscle imbalances. There's all sorts of things that can be causing significant pain that has nothing to do with that finding that's on the MRI. Or it could be the finding on the MRI. It could be either. What's important to know is that the outer part of the disc can heal over time. So just because there might be some disc injury doesn't mean that you're just kaput and done forever, okay? That outer layer, so if we think of the disc as a jelly donut, okay? So that outside layer, that doughy part, is able to heal. The gel on the inside, if that gel has completely escaped out, we've got nothing really holding that disc together anymore, that's the prognosis is not as good for conservative management. But if that gel hasn't completely escaped and it's just some damage to the outer part of the disc, then we want to try and work with that and give it some time to heal and set the patient up into a healing state. Now, when we talk about sprains and strains, okay, here's a picture of the back of the neck, and this is where we've got layers here. On one side of the neck, we've got the more superficial layers. On the other side of the neck, we've cut away the superficial layers. You can see those deeper layers. So this should give you a bit of an appreciation that it's not just one muscle back here. We have a lot of muscles that are all having to work in different ways to control not only how the head is positioned on the neck, but how you're able to move the head, how you're able to move the head on the cranium, and then, or just the cranium itself on the neck, okay? And then how you can move the neck, and then again, moving that mid back. And so when we have a strain to any of these muscles or multiple muscles, it can create a good amount of pain. All right. Postural influence on neck pain. Now, when we go into what we call a forward head posture, so what that looks like, okay, is that my head is not over my shoulders. My head starts going further in front of my shoulders. And I usually go into this more chin up type of position, which is very compressive onto the back of the neck. I've got a picture here that kind of shows the normal head. We'll say it weighs 10 to 12 pounds. So if your head is positioned over your shoulders, okay, and we've got like a 0 degree difference there, then the weight of that head is about 10 to 12 pounds on the neck for those muscles to control. Now, if you go 15 degrees forward, so not that far forward, but just 15 degrees forward, okay, the weight that the muscles have to control equates to about 27 pounds. The further forward that head goes, all the way down to 60 degrees, which is looking at your phone all the time, okay, equates to 60 pounds of stress on the muscles on the back of the neck. So doing that habitually can big time lead to some significant chronic strain in the muscles of the neck. This also is significant for like sitting at a desk, driving, stress. All of these habitual postures create this significantly increased load on the musculature, which can lead to chronic muscle stress, aka neck pain. Now, let's look at what happens when the muscles that are strained start to develop trigger points. Okay, so I'm going to show you a series of pictures that are just common muscles that are strained in this forward head posture. And then when we develop the trigger point, that's just an area of the muscle where we have a little bit of this like kind of knotted up feel. We can feel the knot in the muscle. And then when we feel that knot or that area of hypersensitivity in the muscle can actually refer pain elsewhere. So that's a classic trigger point. Okay. So the sternocleidomastoid is a muscle here on the side of the neck. And then when this one has trigger points, it commonly refers to the side of the head, can refer to the forehead, to the back of the ear. Anywhere in here can be referring pain. So now you've got that headache that you're like, man alive, like this thing just won't go away. It's only on one side. It wraps around maybe through here. And then I come in here and I poke on this muscle and you're like, whoa, that just made my headache worse. That's actually me finding the trigger point, and then we can treat it. And then we can figure out how we can take the strain off of this muscle to get rid of the trigger point long term. That's kind of what leads into the discussion of headaches. Another muscle, upper trapezius, okay? So this is the muscle that kind of comes all the way from the cranium all the way out to the outside of the shoulder. Common trigger points refer out to the outside of the head and to the back of the neck, and then obviously along the muscle line itself. The inferior oblique, sorry this picture is so small, probably should have made that bigger. This is one of those really small little muscles at the base of the head, but when that has a trigger point, it gives you this like kind of around the ear side of the head pain. It's just, again, the pain, the pain isn't from the head itself, it's coming from the muscle. Scalenes, these are the muscles in the front of the neck. They help with respiration. When you've got a trigger point in there, it can refer pain as if you have some sort of nerve impingement. It very much looks like what we call like a median nerve entrapment. So because the pain goes all the way down the arm, it can go all the way down to the fingers. So it can very much mimic a disc dysfunction. Now, other things that can happen, and this is kind of what we're kind of had talked about earlier when I listed everything out. Cervical meniscal entrapment. This one is kind of one of my favorite ones to treat, just because you get such fast results and you get these really big changes. So most commonly, okay, this is, like I said, you slept kind of funny, maybe your head was positioned funny on the pillow, you went to bed completely fine, and you wake up and you're like, oh my gosh, like you cannot turn your head, you can't side bend, and you can't look up. Okay, now it's usually in one direction. So I can turn my head to the left and it's like, okay, that's sore, but I can turn, but to the right, like not going. I can side bend to the left. I mean, it's sore, but then I go to the right, nope, not happening. Like not at all. And then looking up isn't gonna happen. Looking down, sore, but not too bad. So this is definitely something that is very, very treatable, typically resolves within a couple of sessions if we catch it quickly. Because if we catch it quickly, then we can get that meniscus that's been kind of trapped in between the two little bones there, the facet. We can free that up and then try and normalize your motion as quickly as possible. The longer anything stays, the more we get some dysfunctional movement patterns, some guarding, then we start to potentially develop trigger points, and then things just get harder and harder to treat from there. Not that we can't, it's just more complicated. So the faster we can get to this, the faster you feel better, and then it becomes a super easy plan of care. Now, whiplash. This is one we see a good amount in the clinic, just because, you know, being rear-ended is kind of common. Other types of activities that can cause whiplash are slip and fall. So if I kind of slipped back and did that big boom and hit my head onto a surface, there could be a concussion associated with that as well. But any of that big, what we call the hyperflexion and hyperextension, so that all the way down, all the way back motion puts a huge amount of strain onto the muscles in the neck itself. Now, symptoms that you would be typically experienced: neck pain and stiffness, loss of range of motion, headaches, fatigue, and then usually over a 4 to 6 week period, those symptoms get better and better. If it's been 4 to 6 weeks and you're still having significant dysfunction or pain or headaches, that definitely deserves treatment. Even if you're not, like if you're pretty symptomatic and it's before the 4 to 6 week period, you can definitely ask for treatment, like for sure. It can speed you right up and kind of get you through that uncomfortable phase a lot faster. All right. Unresolved whiplash. So a third of people do not have a full recovery on their own. So meaning like I was rear-ended, I did nothing about it, and about a third of the people will continue to have dysfunction afterwards. So the types of dysfunction that can occur are issues with some of those muscles that we talked about in the beginning in the front of the neck, the deep cervical stabilizers. They can stop doing what they're supposed to do, which is really holding onto the spine and giving the spine stability. And then when that happens, all of these other muscles that are more superficial start over responding and start doing way more work than they really should be doing. And then they start developing trigger points and can have pain. And we call dysfunctional movement patterns, meaning like I can no longer rotate in a clean rotation. I start rotating and side bending at the same time, which is kind of compressive on in the facets. And now I start getting facet limitation, and it can lead into just more biomechanical dysfunction than is what is ever necessary. Now, as far as temporomandibular dysfunction, when we talk about that, that's the jaw, okay? So we've got a joint there, and the way that joint is supposed to work and coordinate with both how the joint moves plus how the muscles tug on the joint can become dysfunctional. You can have one joint that moves too much, one joint that moves too little. So now as I'm trying to open my mouth, I might be opening but moving more on one side than the other. Because of maybe hypermobility on one side, or maybe because of hypomobility on the other side. That can lead to compression on one side of the joint, which can lead to all sorts of breakdown at the level of the joint itself. You can get the disc itself can become involved as well, which can give some pretty sharp pain. But then you can also have the muscular involvement of like, I've got muscles on one side that are pulling against a stiff joint all the time. So those muscles are working way harder than the muscles on the other side. So then they develop trigger points. So I've got muscles that help to open the mouth, muscles that help to close the mouth, muscles that help to move the jaw from side to side. Any of those muscles can become involved. One of the muscles that can commonly start to hurt too is what's called the temporalis, which is right here on the outside of the head. And then now all of a sudden it's like, oh man, it's like I'm getting these headaches and my jaw's clicking and making this noise. I don't feel good. Like eating and chewing something that's hard bothers me. So all of that, again, very treatable. It's just making sure that we do a full assessment and diagnose at the level of the joint what's going on, at the level of the muscle what's going on, and at the level of the coordination of both sides of the jaw itself working together, and what's going on there, so that we can specifically make a treatment plan. All right, another really common one are headaches. So headaches can be a real pain in the neck. They really can. Headaches can they can come from many different angles. Sometimes they're from vasculature. And that's when, usually if it's a vascular headache, you can take a medication and it helps, because that medication is going to stop the spasm in whatever vessel in the brain is not doing what it should do, and it's going to open that up, and then the headache goes away. So a vascular headache is very different than a muscular headache, and a muscular headache typically doesn't respond to medication like a vascular headache will. Sometimes taking like an ibuprofen or a Aleve will take the edge off, but it's still a pretty intense headache and it's not budging. Usually a tension headache will respond a little bit more to position. So it's like, if I just sit and relax my head back and I just take the weight, this 10 to 12 pounds or 60 pounds off of these muscles for 30 minutes, that headache starts coming back down again. So that's a little bit more indicative of that muscle related headache. So why does this happen? Okay. Could be trigger points like we talked about before. So scalenes are a perfect example. If you've got a trigger point in your scalene, your SCM, your sternocleidomastoid. So if you've got a trigger point in there and you're getting this kind of over the eye, one-sided headache, then we're really going to be looking at like what's going on with your control of the upper cervical spine, how's your control of mid-cervical spine, and what's going on in that CT junction area. And then let's look at the muscle balance. Let's look at how can you use some of those deep muscles. Why might you be overutilizing this one muscle on one side? Maybe you've got some sort of major imbalance that's coming all the way down to the mid-back. So these are all different things that can contribute to why the trigger point develops. The trigger point leads to the pain in the head, which leads to the tension-related headache. Other things that could be more orthopedic causes for the headaches. We talked about that structure, that postural component, that forward head posture that's habitual, whether it's looking down at the phone all the time or sitting at the computer all the time, and putting that chronic strain on the muscles, then you develop the trigger point. The other thing could be the neuromuscular system itself, meaning that you're not actually talking to the muscles appropriately. Maybe you're a chronic whiplash injury and you lost control of being able to isolate your deep cervical neck flexors, and now you've completely started compensating with your sternocleidomastoid. And so that means that from the level of the brain, the signal isn't being sent to the correct muscle for how to position my head over my neck. So there could be things like that that are going on as well. All things that we would look at during the evaluation. All right, now, what can I do about my pain? Okay, what are my options? So pretty much we have three options. You can ignore it, right? You can say, it's there, I don't have time to deal with it, and I just can't deal with this right now. Maybe I'll modify my diet and it'll go away, or I'll limit my socialization and it'll go away, or maybe it'll just go away. So none of that's really going to change your neck pain. Let's just say let's just call it what it is, okay? All right, now I could alter it or mask it, meaning I could treat the symptom, which is the pain, but not actually treat the cause of the pain. So what does that look like, altering it or masking it? It means injections, pain medications, using what we call modalities, ice, heat, TENS. Those are all fine to treat the symptom, but it's not going to make the symptom go away. It's just going to treat it in the current state. But once you stop whatever that is, the pain's just going to come right back because you never treated the cause. Now, third choice is change it. You can change your pain. So that's what we do is that we have to figure out, why is the pain happening? Address the why in addition to the symptom that you're having. So we always treat the symptom. I mean, we want to calm you down. We don't want you being currently in pain, but we're always looking back at the causative factors. And so why would you want to change it other than, long-term benefit, of course, but then you can also help to really lower your healthcare costs. You can lower your cost of prescription medications. You might be able to potentially avoid surgery, okay? We have minimal side effects. You're not going to have dizziness, nausea, vomiting, potential of death, like you read on every single prescription bottle, okay? And then we're going to have a specialized treatment plan just for you. Okay, it's evidence-based. We use research to guide what we do. We don't just haphazardly say, well, I feel like we should look at this one muscle all the time, every time. No, we look at the research, we try to understand what is going on based on the anatomy, the physiology, what kind of interventions are best, and then from there we treat, okay? Now, when we talk about physical therapy, and you're like, okay, great, Jess, that's awesome. You're going to change my pain. You're going to find out what's causing it and then do something about it. But what does that mean? What does that look like if I were to come in? Okay. So overall, we're always going to start with what we call an individualized assessment. Okay. So we're going to take a look at you from a big look of how is that upper cervical spine, mid cervical, that, CT junction, thoracic spine, how's the strength, how's the posture, how's the muscle balance, and how are the facets moving, how is that jaw moving, everything that might be contributing. Then we're going to look at, how are you sitting? How are you sleeping? How are you lifting? How are you carrying? How do your movement patterns look? So if I can passively move you and it feels pretty good, but then actively I'm like, okay, now let's try and bring that ear to your shoulder. And you So essentially you cannot start with some subcranial motion and then bend. If you're just doing like a weird sideways, like I'm like, whoa, 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 let's try that again. Let's see if you can, and you can't control that. That's going to tell me a lot about you not being able to control the head on the neck itself. You're trying to do everything from all of these muscles down here, but you're not using some of these smaller muscles at all. So that's a huge aspect of what's going on. We got to really work on that. There's all sorts of different movement patterns that we're going to be screening for and looking for. Then, okay, we talk about that postural assessment. So when you sit, you have this tendency to have that forward head posture if you're sitting at a desk or sitting at work or driving, or can we get you out of that posture? Okay. Things that we would be talking about are ergonomic work, like a setup for your desk, whether it's at home or at work, or if you're a student and you're studying. What does it look like to sit properly and have that screen in front of you, whether you're standing or sitting? And doing a combination of the two is really the most ideal situation. Other things we're going to consider are sleeping posture. This is a big deal with neck pain, okay? The pillow and the posture of how that head is positioned on the pillow is a huge contributing factor for neck pain. If you're in a bad posture for 8 hours and you wake up and you feel like a baseball bat hit the back of your neck, okay, then we have got to change that sleeping position. And so sometimes it's just a matter of investing in a different pillow. Sometimes it's completely changing the position itself, i.e. never sleep on your stomach. It's terrible for your neck. So don't do it. It's not healthy. Just don't. We can work on sleeping on your back and setting that up. We can work on sleeping on your side and setting that up, but stomach sleeping is never okay. All of my patients know this. So now, other things that are going to be included. Once we develop the plan of care, we're going to be doing hands-on treatment. So if a joint is stiff, we're going to get it moving. If the muscles are tight, we're going to free them up. If you've got trigger points, we might do some dry needling. We might do some manual trigger point release, but we're going to really specifically treat those trigger points because those are the ones that are referring the pain into the head. So those are the big headache muscles. All right. Now, other things, sorry that my PowerPoint, the background and the text are both white, so it's kind of hard to see the words, but other things that are included in therapy, it's not just the hands-on techniques. Once we get something moving better, we have to teach it how to stabilize. So there's going to be an exercise part of it. So I'm going to retrain some of my deep cervical neck flexors. I'm going to retrain some of those muscles in my mid-back. I'm going to learn how to move in clean patterns. I might put a laser on your head and have you learning how to track, and the laser is giving you feedback, like are you coming up onto this line or down onto a line, and giving you what we call proprioceptive training. So knowing where your head is in space. Sometimes we can lose that, especially after whiplash. And so all of that retraining is super important to follow the hands-on techniques. Now, goals of physical therapy, right? We want to either completely abolish your symptoms or reduce them to the point where you can be independent with management. So if you have some sort of very severe stenotic spine and it's pretty bad, we're never going to get you completely out of pain, but we can teach you how to avoid the big burst of pain and teach you postural changes so that overall you can actually function quite well. It's just, I don't go through life without any pain ever. I have to constantly think about how is my head positioned and what are my ergonomics when I'm typing my notes, or if I'm working with a patient, or if I'm on the phone for a while, am I like this or am I using an earbud? Things like that so that I don't get pain. So it's something that if we're constantly thinking about it, then we're going to be more proactive and then less likely to be flaring it back up again. All right, now a couple things I'm just going to give you if you have any interest in starting on a couple of things that might be helpful, okay? It may or may not, hard to say, I don't know you, but a couple of basic exercises that anybody that's having some neck pain can try, okay? Are the first one is called a chin tuck. So this is using those muscles in the front of the neck that are called your deep cervical neck flexors. These are the ones that hold onto the spine and give the spine stability. So what it looks like, okay, is that if I'm sitting what I'm going to do is I'm going to nod my head on my neck. So it's like I'm trying to give myself a double chin. Now, what I'm not doing is I'm not straining. I'm not really forcing my head back. That's not nice, all right? If you look at my eyes, if I go into a forward head posture, if you try and see where my eyes are on the horizon, right now they're off the horizon. They're a little bit elevated. When I do a chin tuck, what I'm going to do is I'm going to put my eyes right back on the horizon. So then I'm going to hold that for 10 seconds, and then I'm going to relax. And I'm going to do the same thing. So think of myself as a bobblehead, okay? So how that bobblehead's like, so it's not doing this, it's just nodding the head. So I'm going to nod my head back down. My eyes are now on the horizon, and I'm going to hold that for 10 seconds. So I'm going to get some endurance in this muscle, okay? And then relax. So this is one, it's very gentle, okay? Super, super gentle, should not cause any pain, okay? If it's causing pain, you're doing way too much. Easy place to do this, like I tell people, is at a traffic light, okay? Because when we're driving and we're driving along and all of a sudden the head's getting further and further forward, I do the same thing, okay? I don't know where I think I'm going, but my head's getting closer and closer to that steering wheel, okay? The back of the headrest is like, who knows, it's like 10 feet away from my head. So I got to bring my head back at the traffic light. I'm like, find that headrest, okay? There's that chin tuck that I just went into. It's just a really nice way to remind yourself, like elongate through here. Use these muscles to stabilize. Stop hanging on all these yucky muscles that give you pain, okay? So whether you take a break and do this when you're sitting at your desk and you do about 10 chin tucks 10 times, you can be on the phone when you do it. So you don't have to stop what you're doing. If you're at the traffic light, do some chin tucks at the traffic light. Get yourself out of that forward head posture. And then these are things that you can just kind of remind yourself to do throughout the day. And it can take that habitual postural strain off of the muscles in the back of the neck, which over time can start to teach them how to calm down. The other thing that you can do to start working on some stabilization of the neck itself is what we call isometrics, okay? So if you put your hand on the side of your head and you gently push into your hand, okay? So I'm not trying to push myself over, okay? I'm just doing a gentle contraction. I'm going to hold that for 10 seconds and I'm going to repeat it 10 times. And then I'm going to do the same thing on this side, okay? So remember, this noggin here is 10 to 12 pounds. If you were to hold a 10-pound weight in your hand all day long, you can never put it down, your arm would start to get really tired. That's what we're asking these neck muscles to do all day long. So the stronger that you can be in your neck, the better they're going to be able to tolerate that 10 to 12 pounds. The better they can tolerate that, the less strain you put on the musculature itself. The other thing that you can do that's really important, okay, is working on the mid-back. So doing a row with some sort of a band is a nice way to keep that mid-back nice and strong. Now, I'll just kind of give you a quick demo. So if I roll forward at my mid-back, okay, I've done nothing more. I haven't even thought about my head. All I did was relax my shoulders. Look where my head went. It went right into that forward head posture. So I can do chin tucks all day long, but it's not going to change that position of my head, right? If I want this to not feel like 27 pounds on my neck and I want it to feel like 10 to 12 pounds on my neck, then I'm going to have to be strong through my mid-back in order to really tolerate this position. So doing a row exercise means that I'm pushing my sternum forward, okay, and I'm not elevating through my upper traps. So I'm actually going to elongate through my spine as I do the row motion. I'm not doing this, okay? If your arms are coming way back here, just don't. That's completely unnecessary. So it's just a quick squeeze the shoulder blades, okay? Feel like you're nice and tall, and that head needs to be long on your body, okay? And then relax. So start with about 8 repetitions, okay? And do it twice. If it causes pain, you're doing it incorrectly. So none of these should ever contribute to pain. That's the first sign that something is not being contracted correctly, all right? Now, if those don't work, those are 3 very basic not specific to any individual exercises. Those are just in general more postural related exercises that can help with correcting postural dysfunction and take some of the strain off. But if something like that isn't enough to help, okay, you do have 3 options to change your pain. You can come into the clinic for an evaluation and actually have a doctor of physical therapy do an evaluation and understand what is contributing to your pain. Now, if for whatever reason you're feeling really uncomfortable with coming into the clinic in person, we do understand that. Some insurances might pay for a telehealth evaluation. Now, we are way more limited in a telehealth evaluation because we can't actually feel how your joints are moving. It's a little bit harder we can't feel how your muscles feel. I can't feel for those knots. I can't reproduce the trigger point. But it would be a very general way to at least try and get a history and have some working hypotheses and maybe give you some things to try that are a little bit more specific than those 3 exercises. But I will it would be limited, that's all. And then the other thing is to just start with education and exercises. And then if that's not enough, then go ahead and contact us at the clinic. The number, is there on your screen. You can always email us. It's info@pptjax.com. And we'll get back to you with if you're like, oh, hey, I'm tried these couple of exercises and now I'm feeling this or that. What do you think? Then we'll be happy to get back to you. All right. We're just going to leave it open for questions at the end if there's anybody that had typed in any questions. And that's totally okay if not, because I answered them all as I went because I'm that good of an instructor. Just kidding. So we hope to meet you and see you and help you with your pain. And please pass on this information if you know somebody that's in pain, just so they can be educated and informed about what kind of options are available to them. All right. Good seeing you all.